It's always hard to be the last speaker after such good talks and good presentations, and it's also always humbling to be here in front of just so many people that I respect that are just pillars in the community. So I appreciate the opportunity always to work with you and to be part of this amazing many minds approach that we have at Summit and at Utah County. So today we're going to talk a little bit about kind of what's next in orthopedics. Not necessarily all orthopedics, because I can't do that in 8 minutes, but more of a discussion hopefully to stimulate your mind and thinking about what am I going to do next in my practice. So those who have seen this picture may know what this is. This is called the crooked tree. This is the symbol of orthopedics. Most seals of institution, residencies of orthopedics will have this as their main seal. And what it simply means is a crooked tree that they're trying to straighten. And those who garden and work in their yards and do landscaping know that this is a common practice. It was originally penned or drawn by Nicholas Andre, who's considered one of the three main fathers of orthopedics. Now, we don't have a ton of information on him other than that he was a jerk, so maybe that fits, right? But we do know that he penned the idea of orthopedics, that his Latin term of orthos means to straighten, so orthodontia, obviously, and then pedix, meaning children, was to straighten children. That's kind of where we got our start, was the idea of can we make deformities that we were seeing in kids better? But really it was improved by a gentleman named Jean-André Venel, who was actually an obstetrician by trade. His father was a barber surgeon, which again, all surgeons started as barbers, hence my wonderful haircut. He really focused on the poor. He noticed that there was way too many poor that were not being treated with their obstetric needs, and decided that he would write a textbook for all of those who were performing midwifery. I didn't know that was a word. My wife had to double check and say, "Are you sure?" I said, "Yeah, sure." That he actually wrote a manual to improve that treatment for midwifery for the poor. And in fact, he actually opened up a school of midwifery and was one of the first school of midwifery. So he's a founder of both orthopedics and midwifery. So where it progressed is in the year 1776, he had a friend who had a 7-year-old son who had clubfoot on the right side and pes cavus on the left side. So for those who don't know, just congenital deformity on how the body was packaged during the growth process. And he'd been treated by multiple different doctors, and it just wasn't improving. And so Jean-André Venel, his friend, really respected him, and so he brought him over to see him. And as a result, he decided to say, God, there's got to be a better way. Like, I know I'm an obstetrician and focusing on a different part of the body completely, but there's got to be a better way. So he took extra time out of his career to study anatomy, and to study manipulation and how the body could adapt. And he actually invented different devices that look like medieval torture devices, but their whole goal was is there a way that we can straighten with these different devices? And so as a result, he made these devices that you see, some of them for back, for scoliosis, others for limbs, others for fracture care. Can we straighten and hold it in a position? And so that's where orthopedics really started, was from him. And in 1780, he made the first orthopedic hospital. So that's where we get our orthopedic start. In fact, one of the very well-known historians of English talked about his opinion of him as he went to that hospital. And he talked about, I love the bottom part where it says here, ingenious is his method, yet he acknowledges that much of his success depends on mild treatment and continued inspection. I love that. Mild treatment, meaning we're not just going to rush him off to surgery and cut and hack. We're going to see what can we do mildly, and can we continually inspect it and improve. And so for me, that's the foundation of orthopedics. The idea is based on inquiry and improvement, that can constantly asking the questions, what's going on? Am I doing it right? You know, I'm not an orthopedist, I'm an obstetrician, but can I do something better? Can I find a different way? And so he had a desire to make others better because he had a personal relationship with them, and he just wanted to continue to do better and to do less harm, as he talked about, minimally kind of invasive, as we coin the terms now, and constant inspection. So this is the foundation of orthopedics, in my opinion. And, wait for it, the need to hit things is also Orthopedic Foundation. So that's getting a tibial nail out. And yes, those are fun. Winston Churchill coined this, and it's one of my favorite phrases as we talk about continual improvement, as I think about Jean-Andre Venel. To improve is to change, but to perfect is to change often. Now, all of us are in some form of a medical practice as we talk about it, and the reason why it's called a practice is for that idea of continually changing, getting better, practicing something, learning from it, and growing, just like Mr. Venel did. But I love this, is that to perfect is to change often, and how important that is for us to continue looking about perfection. So a lot of it is going to take introspection. So being able to step back and go, is my practice constantly changing, or am I in a rut? Am I constantly doing the same thing the same way? Person comes on with lateral hip pain, do I go, yeah, that's trochanteric bursitis, here's what we're going to do, rather than stepping back and going, God, am I really doing this right? Are we adapting new technologies? Are we looking at what's new? What are the new techniques? Are we injecting PRP in those trochanteric bursts? Are we injecting horse placenta, which, yes, they're doing that, and there's actually some data behind that. So are we continually introspecting to see, can I do better just like Mr. Venel did? Or are we more like this? Yeah, it's fine. I'm okay. Head in the sand. I like what I'm doing. I don't want to change. I'm comfortable. I've been good up to this point, right? But can we continue to improve? This is a wonderful quote from a very well-known author who's written a lot of books about improvement. Once a new technology rolls over you, if you're not part of the steamroller, you're part of the road. And yes, maybe we're talking a little bit about technology, but this also it talks about your technique. If you're not part of that technique, you're missing out on growth that you could be, and you're just part of the road rather than the steamroller. So we're going to go over a few topics that's new in orthopedics, and granted, in this short amount of time, I can't cover it all. So a little bit of what we're going to do is to make you think about, maybe I'm not going to adapt this because I don't do joints like you, or I don't do this or that, but what things can you pull from that and say, hey, maybe with my patients that come in with this knee pain, we could consider this, or if a new technique is coming out there, are you willing to look at it and think about it? So, are you ready? Here we go. All right, first off, we're talking about subvastus approach for a total knee arthroplasty. The gold standard is a median parapatellar, as you see in red, which is simply coming up the medial aspect of the retinaculum, coming around to the VMO insertion and taking that off, and then coming parallel with the fibers within the patella tendon. That's the gold standard. The data suggests that it's good. It's what we've always done. And the new kind of discussion, as we're seeing, is a mid-vastus, subvastus, mini subvastus, just different ways that we can approach the knee with potentially not touching the quadriceps tendon. And the big question is this fast-tracking improvements? Or is this, as we can kind of put it in orthopedic ideas, is this the new DA, or direct anterior, of the knee? Direct anterior, as you know, is kind of the new sexy thing for hip approaches, even though it's been around for a while. It's just kind of what everybody's talking about. And at the American Association of Hip and Knee Surgeons 4 years ago, they took a poll, and less than 50% of surgeons were doing anterior approach. This past year, in 2023, they did a poll, and 60 to 70% are doing anterior approach. So it is changing. So is the subvastus, mini vastus we're seeing people talk about, is that the new DA of the hip? So right after you had tacos and everything, so enjoy this what you see here. But basically, this is a subvastus total knee approach. So it was first described in 1929. It's not new, but it just kind of went by the wayside as the medial parapatellar was doing really fine. In 1988, Dr. Scott kind of increased how they did it. They did a capsular incision as well. So you can see here, see that purple marker that goes up the medial side of the tendon, goes around to about the 3 o'clock position on this right-sided knee, and then veers off and goes underneath the VMO. By simply releasing the fascia, you can keep that complete attachment to the patella and reflect the entire quadriceps tissue off and get the patella out of the way. The idea is that it has the same visualization, but what you're doing is dissecting that intermuscular septum. So here is actually a view of that, and you can see the entire knee. Granted, they're grabbing the capsule, but you can see the whole knee. So we are seeing some good approaches with it, but again, what does the literature show? This is a systematic review and network meta-analysis that showed within the first week an improvement of 27 degrees, but then after the first week, no difference. So does that make a difference? Does that matter? Improved pain scale for the first day of 2 points out of 10. So maybe someone's at 6 points with a medial parapatellar, maybe someone's at 4 with a subvastus. Is that enough? Great question. Right here, they noticed that they had better straight leg raise. And you can see on this forest plot, which in medicine is our gold standard as we look at analysis, you can see the very top, the significant benefit that you can see with a straight leg raise. And the blood loss is significantly less with a mini subvastus, but the operation time is longer with a subvastus, according to this, and the tourniquet time is longer. So is that worth it? As a physical therapist, is it worth potentially the tourniquet time? That's a little bit longer. All right, those are the questions to ask. Another one shows bilateral randomized, which I would have loved to have been a part of this study. Took one side, did a medial parapatellar, did the other side subvastus, didn't tell the patient which side, so it was randomized to which side they would have it. No difference in pain or outcome measures, no difference in patient preference. But you're seeing a lot of surgeons go to this because initially the patients immediately have full quad function. There's not worried about quad tilting or that medial retinacular VMO repair tearing. So potentially quicker return to activities, quicker physical therapy, a little bit more aggressive. So what do we do? That's just a couple. Again, I can't show you all the articles, but these are some big ones. Does this change your practice? Is this something I'm looking into? Absolutely. Something that potentially is gaining ground, so I'm going to keep my ears open and ears to the ground. Robotics. Stryker. Now there's Corey. Now there's Rosa. Now there's Velis. And then, of course, today we have the Think Mini, which is actually really sweet. So I hope you guys take a second to go check this out. I'll talk a little bit about it. But Mako's definitely the gold standard. They set the tone with what it is. It was first to market. They first did it with the hip and then added partial knee and a total knee. Added shoulder should be coming out in Q4 2025. Spine as well, and then eventually foot and ankle. It's a CT-based plan, as you can see in the top right corner. There's intraoperative ligament balancing like you see in the picture in the middle. And then it's a haptic feedback as we're cutting the bones. It's protective. And this is very, very kind of sexy right now in orthopedics. An accurate cut placement. Now we're actually adding on to that in the middle of the case. Can you actually augment it onto the patient's knee with the idea that this will be the plan that every surgeon has goggles that can actually see the CT scan right directly onto the patient as we put these technologies together. The ability to look at everything rather than looking at there and looking there and trying to connect the dots, but actually putting the dots on top of each other. Then we have new platforms coming, just like Think that's here today. This is an open platform. The idea is it's not a huge, big robot box. It's a handheld robot that allows you to put the pins in right where it needs to be. The biggest thing that's nice about it is open platform, so you don't have to go with a specific robot that's a specific company. Maybe this patient needs a different knee than the Stryker knee or than the Smith & Nephew. You could just do the right thing for the patient based on the implant. And it's a smaller design that's handheld. Oh, please tell me that's going to work. Oh, no. Can you check to see if you can connect it, or is it not? It's worth it. Oh, well. Well, sorry. Come up and check it out afterwards. You can see how the pin is placed. It's really sweet. There's some of the data that we're seeing. Again, I'm going to emphasize this is robotic data. Yes, some of this is going to be Mako-based, but the idea is it's robotics in general. We're seeing that in 2018, bone resections are within 1 millimeter. Now, you may not think 1 millimeter matters, but that's the tip of a pencil. The robotic cutting precision is going to reduce soft tissue injury. We're seeing micro soft tissue injury causing inflammatory response that's higher. So if you're not having that soft tissue injury, you're having less inflammation. In Smith et al. In 2019, 94% of patients at 1 year had satisfaction with total knee arthroplasty versus 82. 82 has been kind of the gold standard with what patients are satisfied after a total knee, but with robotics we're seeing that jump up to 94. So an improvement of potentially 10% is worth it. To change your practice, for me it is, and that's why I went this direction. The last one is that forgotten joint score, which we talked about. So what does the data suggest now that it's been out since 2016 for total knees and since 2006 for the total hip? We see the HSS, which is the Hip Society score, the hospital special surgery score, and the WOMAC score is favoring robotic-assisted total knee arthroplasty versus manual, and then we're seeing a reduction in the outliers. And that's the key thing with robotics is the more of these you do, the more chance of outliers you have, right? That's a statistical data that we know. If you can just reduce those outliers, your mean of having a successful case is better. So that's what we're trying to do, is just reduce those outliers, and we've shown that through meta-analyses that we're seeing that reduction. Level 3 data showing significantly shorter stays after total hip arthroplasty compared to just not using robotics, so quicker getting out of the hospital, 50% more accurate in positioning. They took surgeons who do this all the time. They did them with robot and they did it without, and they compared their positioning where they thought they placed it. 50% of the time they were not placed where they thought it was. 92% of the time they were placed within 5 degrees when they did it with robotics. Does those 5 degrees matter? If it's my hip, it does. Does that 1 millimeter matter? If it's my knee, it does. They show that lesser complication rates compared to manual and navigation. They did show it was more expensive, but again, that's different ones that are going to potentially have a higher contract data to it. That's obviously the appeal with the Think and some of these newer technologies, is they can do it potentially cheaper and smaller. But we are progressing. Moving away from robotics is a different approach of how we're doing total knees. So in general, we do what's called a mechanical alignment, which we'll talk about. But if you notice there, that grid, in general, we have about 9 different types of knees. You'll see on the left side is a varus knee, on the right side is a valgus knee, in the middle is a neutral knee. That just has to do with the joint line. Is the overall alignment bow-legged, knock-kneed, or is it neutral? And you can see there potentially is a different angle of the joint line in varus, a different angle of the joint line in neutral, and a different angle of the joint line in valgus for apex distal. So there's 9 types of knees. With a mechanical alignment, it pretty much tells us we're going to treat everybody as a neutral flat, a neutral. I don't have a neutral. In fact, there's a picture I tried to get, but I couldn't find it, of the All Blacks from New Zealand. Their team picture standing there holding each other, and you could look and see all 9 different knees all standing there. So if you treated everybody with a total knee and do a mechanical alignment, you made everyone the same. Is that the right thing to do? As of right now, that's the gold standard. But the new data and things that we're discussing now is kinematic alignment. The idea is we're taking these 9 types of knees, and on the right side, you'll see that's a cut 90 degrees to the tibia, and then you make a rectangular box for the rest of your cuts, because that's where you're replacing metal and plastic. But on the left, you see, what if we accept their joint line as natural and just fit the implants to that? So whatever we are going to replace, let's say it's a 9 millimeter distal femur, we're going to cut off 9 millimeters of bone. That way we don't have to touch the ligaments. We're not doing soft tissue releases. Whatever we're replacing, we're cutting. That's keeping their kinematic alignment aligned. This was really made popular by Dr. Stephen Howell. This is kind of his brainchild, but we're seeing this really take on in the literature. Basically, these are the principles. Don't adjust the kinematics. Cut only the bone that you plan to replace. Don't do any ligament releases. And that's usually if we have a very stiff leg, there's a bunch of ligaments we can cut to release it. Why are we doing that? If that's their natural soft tissues, we want to be soft tissue preserving. This is an example you can see here on the top right and the bottom left are bone cuts that are they're measured, they're calipered. So you can see in the top right corner is a distal cut of 6 millimeters. The saw is 1 millimeter, that equals 7, and you assume with bone-on-bone arthritis that you've lost potentially 2 millimeters. That's 9 millimeters. That's what you're replacing. So you're cutting off and you're replacing what you've cut off, and that's it. No soft tissue releases. Sure, they come in with maybe 6 degrees of a valgus knee. Do you put them back at that? If that's where they started, maybe. So that's the idea. What does the data suggest? Well, they showed one where they're using Mako robotic data where they could get accurate placement and cuts. They showed mechanical alignment versus kinematic alignment showed less pain at 6 weeks postoperatively and a better forgotten joint score at 1 and 2 years. When they looked at kinematic alignment, a meta-analysis, they showed a better knee society score, WOMAC, and knee flexion. When we looked at Mako-specific planning allowed for both kinematic alignment and mechanical access. And I would argue this isn't just Mako. This one specifically is, but this is the point of robotics, is we now have the ability to dial in our cuts, dial in our ligament balancing. So this would apply to Think, in my opinion. This would apply to other potential robots if used correctly. They showed if they tried to do it kinematic or mechanical and compare the two using robotic technology, guess what? No difference. And they said it was not because of no difference, because there's no difference between those two approaches, but that robotics was so good for the patient because it was patient-specific that they were all within 5 degrees of normal 97% of the time, which means basically robotics, whether you're kinematic alignment or mechanical alignment, that's what's best for the patient. Really interesting study. All right, moving away from what I do, more into what Gary does. He's rolling his eyes because it's about time. Quad tendon ACL autografts. No, for me, this is relatively new. This is not new in the general orthopedics, but to me, this hit home when my stake president at my church brought his son to me and had a really bad soccer injury. And for me, I sent him to the best person I knew of, which was a cowboy doctor up in Dallas. And he did a quad tendon ACL. And to me, I was like, this is new. I don't know too much data. They asked me a bunch of questions. I didn't know the answer. They're like, Dr. Pitts, what is this doctor doing with the quad tendon? And I said, this is new to me, so let me figure it out. And the data is pretty compelling. What you can see right here is rather than harvesting certain tissues that are bone or hamstrings, they're just taking the central portion of the quad and using that tissue. That's an example of the Arthrex harvester. This is what Gary does. You can see here the 3 different types of autograft, which is patient harvesting. You can see a bone tendon bone, where they cut out a portion of the tibia, the patellar tendon that's central, and a piece of the patella, which breaks my heart as an orthopedic reconstruction surgeon of the knee. Bone is important to me, so that just really hurts me when I see that. But it was gold standard, and it has been. But we see that it's donor site morbidity, higher incidence of osteoarthritis because you're touching the bone, a greater extensor lag compared to hamstring, higher anterior knee pain with kneeling. Did show faster graft incorporation because bone is healing to bone within the tunnels, and graft-specific post-op PT was key for that because you couldn't do a hamstring type PT versus a bone, patellar bone. But looking at quadriceps tendon, we're seeing smaller incisions, less anterior knee pain, less kneeling pain, less flexor knee deficit compared to hamstring. They're still looking at that for the bone, patellar bone. Equal or better knee laxity, less morbidity of all grafts. And the problem there, the big con to that is deficit in quad muscle, stretch and retraction of the rectus femoris. So you can see the 3 different types of grafts. What we're really seeing is the data is talking about that. But more importantly, it's the technology associated with it. This is something that Arthrex has, and they were the first ones to come to market with what's called the all-inside ACL technique, which is basically you're doing your harvesting. After you harvest, you make your scope incisions, and your scope incisions are where you place your implant. You drill the tunnels, which you can see compared on the left versus the right. Look at the large tibial bone tunnel, small femoral bone tunnel. You can do small femoral and tibial bone tunnels all inside and not having that large scar. When we looked at that, the data you can see on the bottom there, wait for it, showed improvement versus just doing irregular open and tibial tunnels. The last one, rotator cuff augmentation. Basically, we've noticed that there's a higher incidence of patients who are having re-tears after rotator cuff repair. We're being better at identifying those, and there's actually a predictive score. If the score is higher, then there's going to be a higher chance of failure of that rotator cuff. And so there's now new predictive decision-making for when we should be doing augmentation. This is a dermal allograft that we place on top of it, and we're seeing better outcomes as a result of it. This is, again, Arthrex, how they do it, and this is how you insert it. It's not a big incision. It looks like a big piece of tissue, but it's actually foldable, goes through the small cannula, and then deploys almost like a parachute as you place it on top and tack it down. And the data for that is showing improved ASES scores, which is the gold standard, as we're looking at overall shoulder scores. Again, this is something that Gary does. I would say world famous Gary Edwards. So a real quick kind of breathless discussion of what's kind of new, as I could just touch a couple things there. The question that I ask myself every day as I look at the literature, as my wife complains of all the different books that I get in the mail all the time, is what am I going to do next? What am I satisfied with, and what am I going to change? With all these different approaches, am I looking into the things I've discussed? Absolutely. Have I been a Mako guy from the beginning? Yes. But does that mean I'm not looking at Think Robot? No. Absolutely looking at that. I'm a parapatellar guy, but does that mean I'm not looking at subvastus? Absolutely not. Absolutely interested in it. Kinematic alignment, the data is coming out, it's looking good. Now, I can fall behind and become the road, or I can move forward with it and become a steamroller. So that's my question to you guys is, Andre Vanel, his whole point was, how could he make others better around him? And what drives you to do better? For me, it's literature, but again, is that literature good? Maybe the literature's biased. I know I'm biased. I bring lots of bias to you today. Someone here may say, hey, but what about Smith and Nephew? You didn't talk about their joint. You're right. I'm registered, I use that stuff, but I'm biased because of my experience. But that doesn't stop me from keeping it up. The key thing, I think, is being really critical, and I think in the orthopedic community, that's the most important thing, and that's why you're here today. And hats off to you, because it's a wonderful Thursday, it's beautiful out, and you're here. But that means that you're considering what options are out there and how you can improve your practice. Hold on one second. And this is my favorite quote that was told to me by Dr. Stryker, which is, we can use data, we can use information given to us, and we can use it as bias, we can use it to inspire us. And so one of my attendings told me this, Dr. Stryker, often in orthopedics, we use literature in the practice of medicine like a drunk man uses a lamppost, often more for support than for illumination. And my hope for you is that when you look at literature, when you look at the different information that's out there, don't just rely on literature to say, see, I was right, robotics is better. But look at it and analyze it and say, what do my biases tell me, and can I be better, and can I do more for the community, even if I'm an obstetrician, even if I'm just, a chiropractor, therapist, orthopedic surgeon, neurosurgeon. Can I do better in the practice of medicine because I'm critically thinking and not just relying on literature for support? Thank you.